Hello everybody. Over the next few minutes we will discuss a really important question, which is how do you choose the right patient for a prostate MRI? And what I'll try to do is to point out that the main benefits of prostate MRI arise from its rule-out ability, and then take you on to the fact that the rule-out ability is very much dependent on the disease prevalence, and then show you that the major indications for the use of prostate MRI before a biopsy pertains to patients with a prevalence of between 10 and 50%. And then I will follow this lastly by talking about new data supporting the use of prostate MRI in the screening setting and how it might be used in that. And these are my disclosures. So this is the modern MRI pathway. The modern MRI pathway is a risk-based pathway. In other words, the MRI is used to find out what the risk of prostate cancer is likely to be. So we know that patients are assessed initially by the urologist using a clinical evaluation, family history, PSA, DRE. All of these are risk assessments. They may or may not use other tools, such as a risk calculator, for example, a PSA density, which is based on an ultrasound evaluation of the prostate volume. They may use other blood tests or serum tests. But in the end, what they try to do is to separate men at low risk who can undergo a follow-up, no MRI, no biopsy, and people with intermediate and high risk who can undergo a high-quality MRI scan, and after the MRI scan reading is done, then to have another risk assessment that takes into account the MRI information before deciding whether patients are at low risk or intermediate or high risk before a biopsy. When the biopsy decision is being made, it really does depend on the preference threshold for the urologists and the patients. So for example, if a patient is biopsy averse and he's at low risk, then he won't undergo a biopsy. If he is very concerned about cancer, maybe he's got a family history, but he has a negative MRI, for example, you may still decide to biopsy him because of the underlying background risk. So the preference threshold is important. And clearly a targeted biopsy is important because the MRI identifies a target, and of course histological interpretations. Now, of course, you will have men on follow-up who decided not to biopsy. And these men will be followed, and if the PSA goes up or clinical parameters change indicating that you might have missed a cancer, then of course the patient returns and has another MRI before another decision is made. So we need to realize that there are four major benefits to prostate MRI. One, it reduces the total number of men undergoing a biopsy, and two, it reduces the diagnosis of indolent cancers. And this speaks to the rule-out ability. This is the major benefit. And of course, there is a more accurate targeting of the tumor, which leads to improvements in grade determinations, but this is somewhat dependent on the biopsy method. And at the same time, we need to recognize that the prostate cancer diagnosis rates are not inferior to the traditional systematic biopsy route. And these advantages follow on from the rule-in ability of prostate MRI. I just wanted to illustrate these 4 points with a couple of data points. So here is the Canadian multi-center study. Now here we had 453 men who were at suspicion of having prostate cancer, and they were basically randomized. They were randomized to a systematic biopsy or an MRI, and then an MRI targeted biopsy only in positive men. So everybody gets a biopsy versus only people with positive scans get a biopsy. And you can see the results on the right-hand side of this graph. The first thing you notice is the number of men avoiding a biopsy. It's 37% in this particular analysis, what you'll notice is that the number of men with indolent cancers falls by 10% in absolute terms, from 22% to 10%. But look at the detection of clinically significant cancers. You can see that actually rises by about 5%. So it's not inferior to systematic biopsies. And this was also looked at by the Cochrane review, which you can see here. So in the Cochrane review, they aggregated data from 20 studies over 5,000 patients. And you can see here the prevalence is about 30% at the bottom of the slide. These were biopsy-naive men with clinically suspected prostate cancer. And you can see that on average, about 1 in 3 men had cancer, which is the prevalence, but 1 in 3 men also avoided a biopsy. So that is a big advantage. You'll see how the detection of clinically insignificant cancers reduces by an average of about 10% in absolute terms. And you can see that the detection of clinically significant cancers is not impaired. So it's non-inferior to the systematic biopsy pathway. And remember, the MRI pathway is no biopsies for people who have a negative MRI and a targeted biopsy alone for men who have a positive MRI. So this pathway that we just described seems to be effective, and this is the reason why it has been introduced into the guidelines. But if you read the guidelines carefully, what it says is that if you have an asymptomatic man with a PSA between 2 and 10, the so-called gray zone, and a normal DRE, you can either use a risk calculator or an MRI to take men forward. So in other words, it's not saying you biopsy everybody, it's saying assess risk using either a risk calculator or an MRI. It gives a strong recommendation for that. So let's just talk about how MRI compares to a risk calculator, which is based on ultrasound. Now, this was evaluated in a randomized study that was recently published from the Netherlands. And you can see that you had 11 centers that used a web-based risk calculator called the Rotterdam Prostate Cancer Risk Calculator. And you can see the web address there, to assess the likelihood of a cancer. 10 centers used an MRI method. So people who had an MRI with a PIRADS 3 to 5 underwent a biopsy. People who underwent an ultrasound-based risk calculator using the Rotterdam Risk Calculator underwent a systematic biopsy. Now you'll see on the left-hand side that the threshold for the risk calculator is any cancer risk of more than 20% or more than a 4% chance of having a high-grade cancer. So let's just compare the outcomes of these two strategies. On the right-hand side, you can see the main data. You can see that more men avoided a biopsy, about 13% less using the MRI approach. You'll see that the detection of clinically significant cancers is no different between the two arms, but fewer men were diagnosed with insignificant cancers using the MRI approach. So it appears that the MRI approach is in fact slightly superior to the ultrasound-based approach for the detection of clinically significant cancers. So I hope that now you appreciate the data underpinning the use of MRI for prostate cancer diagnosis. As I've stressed, the reduced numbers of patients undergoing a biopsy and reduced diagnosis of indolent cancers is related to its negative predictive value. The variability in the negative predictive value is highlighted over here within this video, but today I want to discuss how the negative predictive value is dependent on the prevalence of disease. On the left-hand side, you can see that the negative predictive value is highly dependent on disease prevalence. The higher the prevalence, the lower is the negative predictive value. And on the right-hand side, you can see how the positive predictive value is also dependent on prevalence. So the higher the prevalence, the greater is going to be the positive predictive value. The main benefit, I've said, arises from the negative predictive value. So if you wanted to achieve a negative predictive value of more than 90%, in other words, you're going to miss fewer than 10% of the cancers there, then the disease prevalence is estimated to be about 30%. If you were willing to miss a few more cancers, say 15%, in other words, your negative predictive value is 85%, you can see how you can adjust the prevalence all the way out to about 45 to 50%. And in fact, you can make further refinements to try to make that ratio even better. So what I've done in this graph is shown you three separate studies. On the left-hand side is a screening study where the prevalence was low at 20%, and on the right-hand side is another patient population where the prevalence was very high, and in this particular instance it's 50%, and I've got that Canadian study in the middle where the prevalence was 30%. What you'll notice is that the main benefit is dependent on prevalence. So you can see when your prevalence was low, 20%, the number of men avoiding a biopsy is huge. Look at that, 64% for MRI-directed biopsies compared to 27% of men with a systematic biopsy. At the other end of the spectrum, you've got a prevalence of 50%. Look what happens here. If you look at the number of men avoiding a biopsy when the prevalence is high, it's much less. It's now 17%. Can you see that? So you can see how the number of men avoiding a biopsy goes down with higher prevalence. The other advantage of the MRI pathway were fewer diagnoses of insignificant cancers. So look at the 20% prevalence. You can see in that the difference in the outputs of the systematic biopsy versus the MRI-directed biopsy is almost threefold. So you can see the systematic biopsy had a 12% insignificant cancer detection. With MRI, it was 4%. And then go to the right-hand side. You'll see there on the right-hand side that the difference between the systematic biopsy and the MRI biopsy is only 1%. So again, you can see how these benefits are related in practical terms on the disease prevalence. So what we're saying is that the men who benefit most from an MRI scan are those men with a low PSA, less than 10, and a normal DRE. These patients benefit most from the MRI pathway in terms of avoiding a biopsy and positive scans that are upgraded by MRI targeting. And those are the blue bars that you can see on the right-hand side. So, for example, a man like this. So here's a 75-year-old man, mild LUTS, a PSA of 7, a normal DRE, and you can see there that there is a PIRADS 5 lesion. So the MRI gives you the target, and you biopsy that target, so this man benefits from the use of an MRI compared to a systematic biopsy. The type of man who does not benefit from a prostate MRI is somebody who has a DRE that's positive and a PSA that's very raised. So a man like this, for example, does not benefit from, on average, from an MRI. So you can see this man has a locally advanced prostate cancer with seminal vesicle invasion. He has bone deposits. So what's the point of doing a multi-parametric MRI with a dynamic contrast enhanced sequence? It really does not make a difference in terms of diagnosis for a man like this. Next, let's talk about screening. Now, in primary screening, what we have to remember is that the prevalence is 4%. That's the background prevalence. Okay? And if you were to do PSAs in the general population, you will see a histogram that you see on the left-hand side. So about 10% of men will have a PSA greater than 3 nanograms per ml. And the reference is given to you there. Now, these men clearly are at higher risk of having clinically significant cancers, which is why that threshold of 3 is often used to screen men for the likelihood of prostate cancer. And on the right-hand side, you can see the European, the EAU recommendations for screening. And you see what they say there. On the right-hand side, they say that if your PSA is more than 3, regardless of your age, then you should undergo a risk stratification. And in this particular instance, it says you can use an ultrasound or risk calculator. And again, something we discussed earlier, you can see it there also. And then if you are at higher risk, then you undergo an MRI, just like we described before. So you can see how the MRI pathway is now being introduced into men in the general screening setting where there is a raised PSA. Now, if you were to use this strategy, what would be the prevalence of clinically significant cancers? So you're not biopsying everybody, you're only biopsying those 10% of men with a PSA of more than 3. And this was looked at by a recent study, which I've illustrated here. So you can see that thousands of men between 50 and 75 were invited to undergo screening, of which 1,532 men had a PSA greater than 3. Now, you can see that some of these men underwent a systematic biopsy, and some of these men had an MRI followed by a targeted biopsy. But look at the prevalence altogether of the number of cancers that were detected. Can you look up at the top on the right-hand side? You can see it's about 20%. So in this situation, we would expect MRI to deliver the benefits that we've already talked about. And in fact, if you look on the right-hand side, you can see the MRI benefits that were in fact delivered. On the right-hand side, you can see that very many more men underwent a biopsy using the ultrasound systematic biopsy approach compared to the MRI approach, which is what we expected. Many more men had clinically insignificant cancers in the systematic biopsy side. And you can see the difference is 4% on one side and 12% on the other side. You'll see that men who had a systematic biopsy were much likely to have a benign diagnosis than a malignant diagnosis. But look, what is the difference in the detection of clinically insignificant cancers? The MRI detects slightly more clinically significant cancers, 21% versus 18%. And that was, in fact, statistically significantly improved on the MRI side. So what we're saying is that if you screen men in this way, with a PSA of 3, by increasing disease prevalence, MRI is able then to deliver the benefits that you want. The other question that should come up is, how many cancers are there in men with a PSA of less than 3? Somebody like this, for example. Here's a 52-year-old man with no family history, some lower urinary tract symptoms, has this diffuse Pyrides 3 abnormality. Is this clinically significant cancer or not? And does MRI help us in this situation? This question was recently addressed by the Prostagram study, which has recently been published. In this study, you can see over 2,000 men were invited to undergo screening, of which about 408 men accepted to undergo screening. They underwent a PSA test, an ultrasound test, and an MRI test. And you can see that in this discussion, we're only going to compare the PSA test versus the MRI test. So a positive PSA was a PSA more than 3, and these people underwent a systematic biopsy. If you had an MRI that was Pyrides 3, 4, or 5, then you were called positive and you underwent an MRI targeted biopsy. The results of the study are shown in the right-hand column. You can see that of the 408 men who were screened, about 167 men underwent a biopsy, which is huge. That's about 40%. 4 out of 10 men who were screened underwent a biopsy. Too many men underwent a biopsy. Why did that happen? It happened because of the number of men undergoing a biopsy after an MRI of 3, 4, and 5. However, if we had chosen a threshold of 4 and 5, then the number of men undergoing a biopsy would have been much less, almost as much as the PSA level. Okay, so that's a very important lesson. And of course, the number of futile biopsies was also higher if you use the threshold of 3, 4, and 5. However, if you look at the detection of clinically significant cancers, you can see that if you use 3, 4, and 5, you had the greatest number of detected clinically significant cancers. So let's just have a look at that last column in more detail. You can see up at the top that the number of cancers detected in the end was 17 out of 408, which means the prevalence is 4%, so a really low prevalence. And let's discuss a strategy of pyrides 4 and 5 with a targeted approach versus a strategy of a PSA that's more than 3, followed by a systematic biopsy for the detection of clinically significant cancers. You can see that the number of men undergoing a biopsy is about the same. So if you use the PSA strategy, you'll need 40 men will undergo a biopsy. If you use the MRI 4-5 approach, then 43 men will undergo a biopsy. So that's not different. Look at the number of men with a non-productive biopsy. It's also the same. It's about 22 in each arm, but there's an improved detection of clinically significant cancers in the MRI approach. You can see if you do the MRI approach and targeted biopsies, you will get 11 cancers, whereas if you used a PSA approach with a systematic biopsy, you'll only get 5 cancers. And that's interesting. But the detection of insignificant cancers is about the same. And of course, you would use fewer biopsy cores if you use the targeted biopsy approach. So there's some early data suggesting that there may be a role of prostate MRI in these early screening settings, provided you use the right threshold, which should really be 4 and 5 when the prevalence is low. So finally, let's answer the original question. The original question is, what sort of men should undergo a prostate MRI before a biopsy? So I think it's now clearer to us. It's men with intermediate and high risk likelihood of prostate cancer, biopsy naive, either on the basis of a raised PSA or an abnormal DRE. It's men who are at persistent risk of cancer despite a prior negative biopsy, and that's well recognized. It's also men who have progressive PSA kinetics who are on that safety net of monitoring after either a negative MRI, but then the PSA continues to rise, or had a positive MRI but had a negative biopsy. Clearly, you would want to use prostate MRI before biopsy in the active surveillance setting, and that is well recognized in the literature. But we've now learned something new, that in primary screening, after risk stratification, in other words, a PSA greater than 3, these men also benefit from the use of MRI. What's common or shared amongst these patients? It's the fact that all these men have a prevalence of between 10 and 50% of prostate cancer. And that is the point. So here are my 5 golden rules for choosing men to undergo an MRI before a biopsy. You need to be very careful about the man you choose based on their likely prevalence. So we said between 10 and 50%, right? These are the men who seem to benefit. Use PSA. You can use a risk calculator, which needs to be calibrated. You can use other biomarkers to optimize the prevalence so you can reap the benefit from the prostate MRI. Risk stratification before the MRI helps reduce the total number of MRIs that you do while maintaining the benefit from the MRI. So if you risk stratify before you do the MRI, about 1/3 of men can avoid an MRI altogether. So you can reap two benefits. You can not only reap the benefit of fewer MRIs, but after the MRI, fewer biopsies. And that is how to deliver the MRI benefit. But we also have to acknowledge that a risk-based ultrasound approach is also performing quite well for the detection of clinically significant cancers if MRI capacity is not there or MRI expertise is not there. I hope you found these comments useful as you begin your own journey on using MRI before a prostate biopsy. Thank you very much for listening.